Hey guys, Dr. Pientka here. Hope you're all staying as happy and healthy as you can, and I hope everybody's families are doing well. I figured during our time away when we don't have any formal conference that I could put together some video lectures for you guys to try and keep the academic environment going and hopefully help motivate you guys to stay on top of things as much as you can. We're not having the same operative experience that we all would like right now, but that doesn't mean that we need to hurt the education any more than absolutely necessary. What I figured we'd do today is start with a lecture I was planning to give you guys in one of our recent hand conferences that was canceled on benign finger tumors. And this is more about developing a differential diagnosis when it comes to finger masses or finger tumors than anything else. The specifics of how each one of these are treated would probably lead to a lecture that was far longer than any of us have the patience for. But I'd like to talk at least about presentation for these and what other things can be mimics and hopefully spur you guys to do a little bit more reading about some of these you may not be as familiar with, but to at least give you a broad overview of some of the more common masses that we'll see in the fingers. As always, if you have any issues, please feel free to reach out to me. Happy to answer any questions you guys would have about this or any other lectures or any other topics related to hand surgery. So let's get started. A finger tumor, really what tumor means is just a swelling, and the cause of that swelling can be a neoplasm or an actual, what you think of as a soft tissue tumor or a new growth. It could be swelling or inflammation. It can be cystic. There can be chemical deposits within the tissues, or it could be the result of a foreign body. And this can all come under the umbrella of tumors, neoplasms, infections, inflammation, cysts, chemical deposits, foreign bodies. They all can broadly be called tumors. And when you're evaluating these patients, it's really important to think of a few things. You want to know how long has this mass been present? How fast it came up. Does it vary in size? For example, the ganglion cyst classically will sometimes be larger, sometimes be smaller, a lot of times in reaction to activities. Find out if the patients recall any sort of injury. Do they have similar findings elsewhere? And I always say, do you have history of lumps or bumps anywhere else on your body? Now, in the past? Any general health problems? And then a family history of any similar issues. And this can be very helpful for things like neurofibromatosis. On physical exam, you want to evaluate these patients very carefully because a lot of times your physical exam can give you a good idea of what you're dealing with. So you want to know, is this a soft, firm, or hard mass? Is it freely mobile? Is it pulsatile? Is it hot or tender? Does it feel mobile with the skin? Is it stuck to deep structures, or is it freely mobile? Does it have an irregular shape? Is it spherical? Does it follow the path of the nerve or the blood vessels? Does it follow the path of the tendon? Does it move with tendon? Are there skin changes, ulcerations? There's soft tissue and bone involvement alone, or just soft tissue involvement? And then, of course, the big things on physical exam that you want to do, with common things being common, are transillumination. And this is really helpful because the most common thing you're going to see is a ganglion cyst on the hand. And this can be distal in the finger or at the wrist where you most likely see them. But especially when you're trying to differentiate between cystic and solid masses, transillumination can be extremely important to help distinguish this. As we talked about before, tumors, especially in the finger, can broadly be categorized as either bony problems, soft tissue problems, and those will both fall under neoplasms, or inflammation, which could either be post-traumatic or infectious, and then more acellular things like cystic masses, fluid collections, foreign bodies, and deposition diseases. Neoplasms, especially the soft tissue ones, are usually benign, and some of the localized ones can be localized to the tina synovium or the skin, nerve tissue, blood vessels, connective tissue, or fat. And those that are localized to the tina synovium, the most common ones you're going to see, number one, are a ganglion cyst. And number 2 are giant cell tumor of tendon sheath. And ganglion cysts, remember, in the finger normally are going to be at the distal interphalangeal joint, and they're going to be in conjunction with an osteophyte, and we call those a mucus cyst. So all a mucus cyst is a ganglion cyst from the distal interphalangeal joint, usually caused by a little of osteophyte or a little bit of arthritis at the DIP joint that cause a weakening in that DIP joint capsule. Now, giant cell tumors of tendon sheath are exactly what they sound like. They originate generally from tendon sheath. You look at them under the microscope, and they're going to have giant cells, giant multinucleated giant cells. And when you look at them grossly, they have a very, very classic appearance. So when you're operating with me and we remove these, which we do not infrequently, and I'll often slice these in half, and you'll actually see the lobular brownish deposits, and it's hemosiderin deposition disease. As far as board exams or the OITE, you need to remember that pathologically or histologically, the giant cell tumor of tendon sheath has the same appearance as pigmented villonodular synovitis, or PVNS. The difference, though, is location. PVNS is a giant cell with hemosiderin deposition within an articulation. Giant cell tumor of tendon sheath is extra-articular PVNS. Moving on, these benign soft tissue masses, if they come from the skin, they can be warts, they can be acanthomas. There's lots of other things that we generally don't see too much as orthopedists, but you can. The schwannomas, the Schwann cell tumors, the neurolomomas, or the neurofibromas can certainly be involved in the finger. Blood vessels, AVM, glomus tumor, extremely common and extremely painful with a very classic presentation distally. These are patients that may or may not have discoloration under their nail, but will have extreme tenderness to palpation around the nail and extreme sensitivity to cold. They cannot tolerate having their hand in cold water or ice water. The thought of that will send them, out of their chair. It's so painful. Pyogenic granuloma, very commonly seen. This is a sort of mountainous appearing outgrowth of tissue that very commonly bleeds, especially if the patient's banging on something. They'll break it open, it'll bleed, and this is something that can be really sort of frustrating to treat, but usually is treatable. And then aneurysms or pseudoaneurysms do happen in the digits. Often it can be a result of trauma. The few that I've had over the last couple of years, one of them was from a thorn injury, had a radial digital nerve or artery aneurysm, and then I just had a large radial artery aneurysm recently that we removed in conjunction with a carpal tunnel. Dupuytren's disease is basically benign soft tissue neoplasm or new growth localized within the palm, and then lipomas do happen in the hand as well. And these soft tissue tumors that come from the tenosynovium or the giant cell tumor of tendon sheath, these can have a very characteristic look, but they can range from just a small mass, as you can see here, to something bigger like this. And then when you open them up again, you've got this lobular sort of brainy appearance, and you can see the dark hemosiderin deposition. It almost has an orangish or yellowish look to it grossly here in this picture, and this is exactly what these will look like. These are the most common neoplasms in the hand. They are firm and lobulated, and they'll always originate near a tendon. Now, it can be flexor tendon or extensor tendon, and these do have the tendency to be locally aggressive, and they can wrap all the way around the finger. They can engulf the neurovascular bundles, but these are extremely common, and you should know what these are when you see them. Skin lesions, benign is all we're talking about here on the fingers, but can be warts, they can be keratoacanthomas, and these oftentimes should be going to dermatology, but it's important for you guys to see these and know what they are to recognize and be able to provide some guidance to your patients. Localized nerve tumors, specifically the schwannoma, These are spindle-shaped or long, elongated swellings in the digital nerves. And instead of moving proximal to distal, uh, like you would see in like a ganglion cyst or something like that, when you palpate these are going to move more palmar dorsal because that digital nerve is going to tether them from moving proximal to distal. And that's how you can distinguish swelling along the nerve. They could be a neuromyoma or a schwannoma from something else like a ganglion cyst. Tumors that involve the blood vessels here, number one can be AVMs. And what you get with this is basically just a nest of blood vessels. And this can sometimes give you discoloration on the skin. Sometimes it's just a localized swelling and you only see it on ultrasound or MRI. A glomus tumor, these are actually neuroarterial in origin. So these are very small blood vessels, usually under the nail or the ungual region. And again, these can give you discoloration on the fingertips, like you see in the top right here. These can be extremely painful, or they are extremely painful. They can cause nail deformities. And again, the most common and specific finding is that temperature sensitivity. Pyogenic granuloma, which you see here on the top left, is sort of this fungating soft tissue mass that's very friable tissue, very easy to bleed. And this is something that we treat with silver nitrate application, oftentimes over the course of multiple weeks. These will likely resolve, and these can be a reaction to injury. Oftentimes, a lot of these blood vessel issues can be a reaction. And then connective tissue disorders, the most common being Dupuytren's contracture. This is rare in the digit alone without having something affecting the palm. So it's very common to have a palmar cord without a digital cord, but very rare to have a digital cord without a palmar cord. As far as testing purposes, it is important to remember the types of cords and their originating tissues. Remember, the pre-tendinous cord is the palmar cord that causes an MCP contracture. The notatory cord is the cord in the web space that causes the inability to abduct a web space. And the spiral cord is the most common cord causing PIP flexion contracture. And it's the spiral cord that gives the characteristic displacement of the neurovascular bundles to a more centralized, superficial midline position, but that's at the base of the finger or around the MCP level. And you guys will see this as we do some of these fasciectomies on the hand surface in the future. It's also important to know when you're offering surgery to these patients or talking about things like the collagenase injections. Collagenase is very good for strong pre-tendinous cords. It's pretty good for spiral cords with a PIP flexion contracture, and often not as effective at all with the notatory cords, which makes sense because the way the collagenase works is the enzyme gets injected into the tissue and it helps dissolve or eat away that abnormal collagen within the cords. And then a couple days later, you come back and you manipulate the digit into extension, and it actually separates that cord without tearing the skin most of the time. But you cannot do the manipulation to spread the fingers apart enough to separate the notatory cord, nor is that often a debilitating finding. So make sure you're not counseling the patients that they're going to be able to spread their fingers apart, and you're going to relieve the notatory cord with a collagenase injection. Soft tissue neoplasms that can be systemic, can involve connective tissues, blood vessels, neurofibromas, which are rare in the fingers but do happen, or can come from the tenosynovium. But again, these are systemic issues. And this can be, something like Dupuytren's, although Dupuytren's can happen elsewhere in the body. It can happen in the feet, which is called Lederhosen disease. The knuckle pads, which you see here in the bottom left, and on the dorsum of the interphalangeal joints, those are called Garrett's nodes or knuckle pads. And oftentimes patients will come in wanting these removed because they think they're strong calluses or tumors, but these are actually an early finding of Dupuytren's disease. You can also get this condition in the penis, which oftentimes, patients are not going to tell their orthopedic surgeon about, but you could be the first person they talk about their connective tissue disorder with. So you want to make sure to ask them about their feet or any penile contractures as well, because those can also be treated if caught and referred. Rheumatoid arthritis is another systemic problem that can cause connective tissue injuries, and this often causes swelling and nodules around the fingertips, around the elbows, and characteristic findings in the hand, which you see in the top right, where you get the ulnar drift at the metacarpal phalangeal joint. You also get a caput ulna, which is a prominent ulnar head that you see there, and that's actually the ulnar head stays where it's supposed to be, but the soft tissues that hold the ulnar side of the carpus of the ulnocarpal joint up become incompetent, which causes the ulnar wrist and hand to fall more into a supination position, making the ulnar head appear prominent. And then that prominence of the ulnar can lead to what's called Vaughan-Jackson syndrome. And what Vaughan-Jackson syndrome is a sequential failure, attritional rupture of the extensor tendons of the extensor digitorum communis, starting with the small finger, and then the fingers will drop sequentially, moving from an ulnar to radial direction. Systemic blood vessel issues can be AVMs, and these can be things like Maffucci syndrome, where you've got these diffuse intravascular calcifications, and oftentimes these patients have these all over their body, but certainly in their hands, and they can really develop significant hand deformities as a result of this. Synovial neoplasms that are systemic can be from rheumatoid arthritis, and tenosynovitis is extremely common in these rheumatoid patients. And a lot of times you'll see this in the dorsal wrist, around the extensors. You can see it in the flexors. It can be a cause of carpal tunnel syndrome, where you get this just profound proliferation of tenosynovium in rheumatoids. Localized bony neoplasms, the enchondroma, is extremely common in the fingers, often is incidentally found, but sometimes patients will break through this and they'll show up with a fracture, a pathologic fracture in the digit, and it's the first time they find out about their enchondroma. And what you see is an expanded metaphyseal lesion that usually doesn't destroy the cortex, but it can cause thinning of the cortex, as you see in the middle image here. They can get some calcification stippling within it, and sometimes these will actually resolve after a fracture. That process of ossification of the fracture and the healing will actually cause the cartilage within the enchondroma to transition to bone. Now, enchondromas can be a systemic problem, and when there's multiple enchondromas, we call that Allière's disease. If there's multiple enchondromas in conjunction with multiple hemangiomas, as we saw on the previous slides, that's a condition called Maffucci syndrome. And the difference between Maffucci's and Allière's really comes down to the risk of malignant degeneration. Maffucci syndrome has a near 100% risk of malignant degeneration of at least one of the enchondromas. That risk is much less in Allière's disease. And certainly both of them have a higher risk than a solitary enchondroma. Of course, osteoarthritis can cause bony neoplasms, which are really osteophytes, and these can be at the DIP, which we call Herbert's nodes. These are extremely common, or they can be at the PIP, which are less common in osteoarthritis, and those are called Bouchard's nodes. Bony neoplasms can be aggressive, but still benign, and giant cell tumor of bone is one of those. And these have a really characteristic appearance. They can be confused with enchondromas early on, but what you get with these is you get a expansile lesion that really thins and destroys the cortex. You can see these in the distal radius and the distal ulna and the metacarpals. You can see them in the fingers, although it's a little bit less common there. These have an extremely high local recurrence rate, and they can metastasize to the lungs is where they generally go. And you should remember that the two benign tumors that metastasize are giant cell tumors of bone, not to be confused with giant cell tumors of tendon, as well as osteoblastomas in kids. And these should be treated aggressively with a wide local excision, or sometimes you even need to consider amputation. Moving on to the more acellular neoplasms in the fingers, ganglion cysts and mucus cysts. Again, remember a mucus cyst is a ganglion at the interphalangeal joint distally. These are usually just dorsal to the midline when they're coming from a joint. They're usually in the midline volarly at the proximal flexion creases. They will transilluminate. They're often freely mobile. They can wax and wane in size. They're usually not tender. They're more annoying for the patients. They do have a very high recurrence rate. So ganglion cysts, the general guidance that I tell patients, which is pretty easy to remember, is your recurrence rate is dependent on your treatment. If you aspirate a cyst, it has a 50% chance of recurrence. And that's lifetime recurrence. If you excise a cyst, it has a 15% recurrence risk. And this risk stays the same. So if you have a ganglion cyst and you have it excised and it comes back, re-excision still has a 15% risk of recurrence. Now you can decrease this risk by doing a few things. In the digits, you want to make sure to get that offending osteophyte and remove that. In the wrist, oftentimes ganglion cysts are going to come from the scapholunate interval dorsally. And you want to make sure that you get down to the stalk at the scapholunate ligament and cauterize that, removing the whole stalk. But another thing you can do to decrease recurrence risk in the wrist, especially dorsally, is to remove like a 1 by 1 square centimeter portion of the wrist capsule dorsally. So there's no tissue there to fill up with the synovial fluid and form a new cyst. Inclusion cysts are usually a site where they had a previous pinning or injury, and epidermal inclusion cysts are caused when the epithelium gets pulled inside the body that then heals that over, but that skin cells continue to produce keratin. And these are hard. They're usually going to be on surfaces that are contact surfaces, so palmar tips, or on the radial aspect of the index finger where you pinch, or where you've got side pinch. They don't transilluminate. They're usually not mobile. Sometimes these will rupture, and patients will say that they had what looked like pus or a toothpastey type substance come out of their finger, and then it goes away, and these a lot of times need to be surgically excised. These can also invade the bone too, just from external pressure. Chemical deposits or calcium deposits are not uncommon in the fingers. These can be calcium deposits within the arteries, within the soft tissues, and calciphylaxis, or things like lupus. Tendon calcifications from previous injuries. Pseudo gout can cause calcium pyrophosphate deposition into, specifically you often see that at the TFCC on a wrist x-ray. You'll see calcifications there, and that's a sign of pseudo gout. Or these can be from external injections, things like paint injections. If they're specific types of paint, will show up on x-ray. And these can be pretty impressive when you look at them. Gout specifically can give you an appearance here like you see on the bottom right, and these are uric acid depositions. And what we call these are gouty tophus, or tophi is the plural of that. And these can cause joint erosions, especially around the DIP. And these can be extremely painful for patients. Sometimes they'll rupture, and they have this appearance just like you see in the middle. It's really like a Colgate toothpaste. You open it up, and it's just sort of around everything. And you can remove a lot of it, but you can never get it all out. But you need to counsel patients that if they don't get their uric acid or their gout under control, that these come back for sure. So that's just about going to do it for our benign finger tumor lecture here. It's just a very brief overview of a lot of the common things that you'll see when you're evaluating these patients. I hope that this clears up some of the differential diagnoses for you guys, and I hope that it spurs some questions for you. And questions, this is more about identification and developing a differential diagnosis than treatment options. But you will see these come up, and I hope that this spurs you to sort of read more about some of these or ask questions. Certainly, we can talk about this when we're in clinic and we see these patients. I think those are great learning opportunities for you guys. But reach out to me and let me know if you have any questions about benign finger tumors. I hope you all are staying very safe during this time and hope to see you all back soon. Thank you.